Watching seasons change, our roads were lined with adventure, mountains in the way, couldn't keep us from the sea. Here we stand open arms, this is home where we are, ever strong in the world that we made.
For the kind introduction. I don't know whether I'm the best person to talk about effective communication, but let's just me try to share my slide now. Ooh. Can you see my slide?
Yes, Prof.
Oh, you can. Okay. The system said cannot. Okay, right. Let me. We did a trial run just now, so I hope this works. Can still see?
Boleh, Prof.
Okay, right. So we just get on with this. So thank you for inviting me to give this PPD talk on effective communication. It's so important, I think. When I was Dean, I suggested this to Prof. Harlina at that time, and she agreed that postgraduate students should also be given training in PPD, and one of the modules will be on communication skills. What I'm going to do in this talk is to ask 5 or rather 6 questions. Firstly, what is communication really? Why is communication important for doctors? What are the general principles of effective communication? How do I conduct a patient interview? How do I break bad news? And how can I clerk a patient effectively? It sounds very long, but a lot of these are just 1 slide or 2 slides only per question. Maybe towards the last 3 bullets, I spend more time because that's where the training is actually for today. Okay, so what is communication? It is really an interaction, how we interact with people and how we relate to them. It will involve not just speaking, but also listening and understanding with passion and respect. That's very important for us. This is not just for doctors, but everyone does that sometimes unconsciously. Yeah, it may be verbal or non-verbal. So your body language, the tone of voice, as I'm speaking now as well, yeah, to get your interest, and whether it's written, it's still communication. And complete silence, believe it or not, it's a form of communication, right? So we'll go through this in detail later in the talk. And such encounters may cover exchanges of not just knowledge, but also desires, needs, perceptions, yeah, emotions, views and ideas, and so on and so forth. These are just some examples how things are transmitted from one person to another. So why is communication important for doctors? I think you all know this, but just let's go through this systematically so that we understand, and hopefully it will be embedded in our mind till we die. So firstly, I think you know this, that poor communication or miscommunication is a major source of medical, legal, and ethical problems. I'll just give you an anecdote. I was pengarah of the hospital in UKM, yeah, Hospital Chancellor Tunku Muhriz, and the husband of one patient came to see me and complained about a doctor. Okay, so this doctor did surgery on the wrong foot, you know, and that was not the main problem. It is wrong foot. The problem was, first problem was that nobody, the first person who examined did not mark the foot. The patient also was already under GA, and the nurses, the doctors did not look at the x-ray properly and did not check. So the wrong foot was operated on. The problem was communication. The doctor did, what the doctor told the husband was really, really not good. Yeah, the doctor said, it's lucky that your wife got operated on the other foot. Now she doesn't need to operate the other foot in the future. So that really gave me a headache. And that was the start of a miscommunication and of course, legal proceedings as well. It's also a major source of refusal or acceptance of treatment, yeah, inadvertently because of your poor communication. And I'm sure you all have experienced this as doctors, yeah. You all are in first year, but when you were, house officers, medical officers, often your relatives or friends would seek clarification from you after having seen another doctor. Can you please explain again what he meant? That shows that that first doctor did not communicate properly, so it's not clear to them. If it was clear, made in plain language, they wouldn't have come to you to ask for explanation anymore. Yeah, so this often happens when I balik kampung. You visit, neighbors come visiting, they'll ask you, and now with text messages, can you please explain what this means? So that's not good. And historically, the medical curriculum emphasized many hard skills, physical examination skills, history taking skills, but not soft skills, which is very important. And I'll come to that again later. So learning how to communicate effectively is now part of any contemporary medical curricula. And it's a compulsory station in the MRCP PACES exam. For those of you doing internal medicine, you will know this. And in undergraduate curriculum is now an important component. So what are the general principles of effective communication? This is like the pillars or the rukun, yeah, of the 4 rukun of communication skills. Yeah, starting with thinking, what to say, and the thinking process, the reasoning as we communicate with our patients or the caregivers, listening, speaking, of course, and then there's non-verbal communication skills, which are actually done usually unconsciously. Yeah. Let's take an example. Yeah. If you are clever, you know what you're talking about, a genius, but you don't have the skills, your patient will be left wondering what the hell was going on. Whereas if you are clueless what you're going to talk about, even though, if you have poor communication, it's even worse. Yeah. The patient will be totally doubly confused. If you, again, don't know what is going on, you're not sure, but your communication is effective, still no good. Yeah, you have to have the content, that thinking part of that. Of course, the best is to be knowledgeable about it. You know what you're talking about, an expert in that field, and you look after the patient, and the communication was effective, the patient is left happy. Yeah, there's this situation as well where you are good, you know your knowledge, you know your stuff, effective communication, but the patient's still confused. There's something wrong here. That's a red flag. Either you have no insight, or you are demented yourself, or the patient is demented or has poor insight. Yeah, so this, you need to refer to someone else. So this happens as well. So you need to know these 5 possibilities in communication. And you don't want to do this, right? Use jargon. So here's a cartoon showing that you need a dictionary. For poor patient has to find out what all those words mean. It's like a dog talking to a cat. Or in Malay custom, we say, macam itik cakap dengan ayam, which is not going to be effective communication. And please don't be a single worder. I call it single worder doctor. Penicillin, this is also not good. Might be accurate, might be clever, but this is very poor communication. So these are the principles. Yeah. Firstly, and the rationale behind it. Effective communication will ensure a good working relationship. The patient relates to you better if you can communicate effectively. It will, of course, increase patient satisfaction, increases the patient's understanding of the illness and the whole management plan that you're going to draw up. And of course, it improves compliance with any treatment you're going to prescribe. Yeah? Improves, may not be 100%, but it will improve. And it requires planning and thinking in terms of outcomes. This is a bit more difficult to do. Most of us would just go and see the patient without planning what to say. Usually it's standard, but you still need to plan. And it follows what we call a helical model. So what I say influences what the patient will say in a spiral fashion, and coming back around the spiral of communication at a different level each time is what happens during a communication, And you have to show empathy and then how to handle emotional outbreaks, and I'll give you some tips to this. This is a common question in the exams, yeah? And we listen how you communicate with the patient. So with whom do we communicate? Just to remind ourselves that we may overlook this, right? Of course, patients and caregivers, our colleagues, yeah, at the same level, or your superiors, how you present the cases to them. Administrators, yeah, you're going to talk as maybe as a team leader for that multidisciplinary team. You are the leader. You need to know how to communicate with them. Nurses and other auxiliary or support staff, the media, right, and the public. It's important to speak in plain language, easy to understand, and of course, attendees of scientific meetings and conferences. And not to forget how you communicate with the lawyers when you give evidence in court. I've been to court, not because I was charged, but my friend was charged, a friend of mine, in a private hospital, and I regretted trying to help him. The lawyers are much better than me in communicating what their thoughts are, you know. So this is, I'll come back to lawyer skills towards the end of the talk. So these are important people that we talk to and communicate with. What I'm going to do is to concentrate on the first three bullets, history taking, breaking bad news, and how to conduct a consultation, yeah? The results of your examination, investigations, prognosis, treatment, and obtaining informed consent. So these are important things to do. But I won't talk about obtaining informed consent. Maybe that's given by a different lecturer later on. Oops, sorry. So, right. So communication with patients and caregivers, yeah, we'll start with how this is important for medical care. A good communication should really be established upon admission itself, yeah, between the patient, the family, and the multidisciplinary team. Yeah. And patients and family members are encouraged, that you should encourage them to participate and speak during the ward round discussions. Yeah? You do the ward round, but after that, you should meet with the family, talking about the medical care and treatment, if there are any rehab plans, and follow up appointments, readmission plans, and of course, any doubts and concerns that they have. The last one people tend to forget. Do you have anything else you want to say? Are you concerned about anything after I've explained this to you? I think that's important for closure. So I think we should individualize the amount and type of information. And you should enable the patient to feel understood, valued, and supported. I tell my trainees that when you speak to a patient, you give the picture that you have your undivided attention. Actually, you have a lot of other things to do, but if you can do that, make the patient feel that the patient is the only patient for that day, that would be good, yeah? They have this personal touch, one-to-one communication, and treated like a private patient in a public hospital. That's one of my mottos, yeah? You're giving private service in a public hospital. You should explain in simple layperson language. I mentioned it earlier about jargon, so the patient can remember and relate this to his or her illness. We should actively involve the patient in the discussion and management plan. I sort of mentioned it earlier. There's a lot of repetition here, but I want to stress these points when in this talk. And we should encourage an environment that maximizes accurate and efficient information gathering, planning, and explanation. All this must be done all in one to get the patient rapport. Do not laugh or whisper. You may laugh or whisper at something else, but I've seen this happen during ward rounds. When my MOs laugh, they probably laugh about another MO, but the patient thinks they're laughing at them, or whispering. And do not assume the patient cannot speak English. You sort of tell your friend, apa lah makcik ni dia apa bodoh ke apa? This is so bad. You will be surprised, yeah. Patients coming from kampongs or a foreigner from a different country that doesn't seem to speak English, you don't do that. And please address them by name. We tend to do this. Overseas, when I worked both in Australia and England, we call them by name, Mr. Brown, Miss John, and so on. But we here will say, oh, pesakit yang ada ascites tu, Pak Cik yang duduk sebelah katil nombor 9 dekat tingkap. These are things which we shouldn't do. We should address patients by name. That's the personal touch that we want you all to show in your day-to-day practice. You should establish a supportive environment. Find a quiet room or area if there's no room. Your tone of voice, should be is important. You have to train with this. Sometimes your voice is monotonous, like you're not interested. And of course, your body language. Whether you smile or you never smile. Lack of emotions. And what we call a poker face. That's not good. You should show your smiling face, your approval, nodding, and so on. These are important. These are called things that you do during your body language communication. You should be aware of the patient's emotional state. I'll come back to that in more detail later. And identify all the problems and concerns that the patient has. If possible, when you consult, you should agree, you and the patient should agree on an agenda and a plan for the consultation. And make sure, again, the patient is part of the collaborative process. Now, how do you close this? First, confirm the established plan of care and management. You see, like this doctor in the picture on the right, the top right, he will take the patient to sit beside him, and then, or below, the same with the patient below with COVID now, so you have to wear your mask, but you can go that close and then explain, showing the results on the computer, or your plan of management. Patients are allowed to read their own notes, or a scan you want to show. That I do that often as a neurologist. We show the brain scan with a brain model on by my side to show how we do the cuts to the slices the brain, and then clarify the next steps for both the doctor and patient, what they're going to do with you, how they can communicate back with you. Try to establish any backup plans. So that's important. This is what I do. If you want to say increase to withdraw or to reduce, to wean off anti-seizure drugs, for instance, as you know, if you do it suddenly, you can get what we call withdrawal seizures. So let's say you go down a bit, and then the patient gets seizure, you have to have a backup plan, what to do next. By doing this, you can also assure that the patient will adhere to your prescription, and make efficient use of the time during the consultation. If you plan properly, you won't take too long to show that the patient, that actually you care for them, as if they had all the time, but actually it's limited to 15 minutes, for instance. So how do I conduct a patient interview? I took this reference, from Walter Bale. It's called the class protocol. And I like this because it's very organized and a way to train people like you, So class stands for context, listening skills, acknowledgement or acknowledge, strategy, and summary. So the context is the physical setup for the interview. Then, of course, listening skills, how to be an effective listener, and then how to validate, explore, and address emotions and concerns. Then how to provide a management plan for the patient, and then summarize the consultation. So, as I mentioned earlier, choose a private and quiet room or area. You don't want to be interrupted by too much noise, too much movement. Someone's drilling or doing some renovation in the ward that frequently happens in our hospitals. Find it in the area which is quiet. Maintain eye contact except when the patient becomes upset. I noticed some doctors, if you remember when you all got into medical school, when you had to do a medical checkup, many GPs do not have eye contact. They just, talk to you, less looking at the notes, couldn't care less what you look like. And look at the first photograph on the top right, have your eyes at the same level as the patient. So a pediatric patient, you have to kneel down and talk to that girl like this, rather than stand up and be domineering. That's not good. You should remove any physical barriers between you and the patient, between the two of you. So you don't want an X-ray box sitting in between. You don't want a pile of your textbooks in between the two of you. Present a relaxed demeanor. You must look relaxed as well and happy to talk to them. If you look tense, they will be tense. have a box of tissues available. You should do that. In the clinic, insist. You may use it for yourself for other purposes, but in case the patient needs that, looks as though you care for them. And remember, only touch the hand or forearm to comfort the patient, and not anything else, okay? But be aware of cultural beliefs. So if a Muslim patient is wearing tudung labuh, ya, janganlah belik-belik, angkat-angkat tudung dia, cari tangan dia. You know, that's not good. So you have to respect cultural and religious beliefs. So that's one thing. So you can probably tap on the shoulder, over the clothing and so on, or don't touch at all. That's okay. Yeah. So these are things that you have to be sensitive to. Use open-ended questions for listening skills. Yeah. I'll come back to that again later when about history taking skills. So that's important. Allow the patient to speak without interruption. I notice doctors like to interrupt. Let them finish, because if you ask them a question halfway, actually they're going to tell you anyway, you know. So if you have so many breaks, you break the train of thoughts, it's not good. Let them speak. Listen. Yeah. Not to the patient, to let the patient know you are following them. And then repeat a key word from the previous sentence so that they can continue. Like, so if I understand you correctly, you are saying blah, blah, blah. Preempt the patient. Yeah. Sorry, that's a spelling error. If you know you will be interrupted by time constraints. For instance, before we start, I got to tell you that at 10 a.m. I've got to go to the operating theater. I have a case to do. Or I'm on call today. I may be paged. I may be called. And I have to say sorry if I have to do this. Yeah. So you have to, if you preempt, they won't be upset with you. If you don't warn them about this, they're going to be upset. Yeah. Halfway through an emotional outbreak, you run away. So that gives a wrong impression that you are running away from their feelings. Acknowledge emotions. Yeah. So you have to identify the emotion, anger, worry, anxiety, right? And identify the cause of the emotion. So respond by showing you care. Like, for example, you say most people would be upset about this. And that's it. Don't say anything else. You do not have to have the same feelings as the patient. Yeah. Patient menangis, you pun mula menangis dah. That's not good. That's not a good doctor. You cannot, you don't have to share the same emotions as the patient. And of course, you do not have to agree with their emotions and their feelings. You don't have to, but you don't have to say it. I don't agree with you. So that's not good. But you don't have to have the same feelings. And this comes to the S, yeah, the strategy. So appraise in your mind or clarify with the patient his or her expectations of treatment and outcome. Yep, you've gone through this, but you have to clarify this. And decide what's the best medical plan for them. Individualize this. Recommend a strategy on how to proceed, a strategy. Evaluate the patient's response. Yep. And then collaborate and agree on the plan and contingencies, the backup plans. And in summarizing, you know, what I do, those of you who were my students before will know, yeah, I would like a whiteboard marker in my clinic. At the moment, I don't have one in UiTM. I'm so upset because the building doesn't belong to UiTM yet. It's on loan. So we cannot nail anything to the whiteboard. And I couldn't get a whiteboard on wheels, which would be good. Because by doing this, you can draw, you can write, summarize the discussion that you just had in a clear and concise manner. They will understand better. At the top right photograph, I was doing the spirogram for Parkinson's disease for tremor assessment. So I'm just telling them why I do that. You know, short of doing a video. So this is how we record it in the notes, right? And then if you don't have a whiteboard, what I do now is to have a clipboard with a lot of recycled A4 paper, you know, the back of a form and so on, which was spoiled, and then go through with them, draw with them, so that they will understand, right? So this is the second bullet, checking the patient's understanding. And ask the patient again if they have any other questions or concerns. And if you have run out of time, because you have to go to OT and so on, you can tell them that they can communicate with you via email, if urgent, or otherwise at the next appointment. And make a clear contract for a follow-up visit, meaning, you know, appointments given, tell them why it's important to come for the next appointment. Let's go to breaking bad news, which is often a common question in exams, especially for those doing MRCP as well. It's so common. But this is also common in our MET exams. If you get a long case that, you're supposed to break bad news, you have to say how in the Viva as well. So bad news, yeah, it's not just like you're going to die, or sorry, you have cancer. It's any news that drastically and negatively alters the patient's view of his or her future. So that covers a lot of things. It will result definitely in cognitive, behavioral, emotional behavior of the patient. Yeah, and in a way, you have to balance between protecting patients from disheartening news versus patient autonomy. Patients have the right to know, yeah, but how you do that, you need the skills to do that. Clinicians are responsible for breaking bad news, but we are not formally trained. Yeah, so this is one of the training sessions. There'll be more, I'm sure, as you go to your own master's program. So this is the SPIKES protocol. Yeah, S is for setting up the conversation. P is perception. I is invitation. I'll explain it to you in a minute. K is knowledge. E, emotions, and then strategy and summary like the previous one. So again, identify a quiet, undisturbed area. This is even more important than the previous one, right? And then you prepare what you're going to say, right? How you say it. So this is important. It won't take so long. It takes just a few minutes. And you have to anticipate the family and patient reaction. It will happen, right? And have the key people whom the patient wants, yeah, in the room. Might be the husband, wife, might be the children, yeah. Sit the patient closest to you. Again, no barriers in between. And then the husband or wife next to that, yeah, but the patient closest to you. Sit down, try to be calm. Make eye contact, yeah. You have to be calm yourself. P is perception. So ask the patient what they already know, the caregivers as well. So tell me what you understand about your condition so far. And assess the patient's and family members' level of understanding. So take note of any discrepancies, yeah, in the patient's understanding and what actually is happening. So you may have to rephrase, sorry, spelling error again, or paraphrase to improve understanding. And you got to watch for signs of denial, where you have to take a step back and review. So the invitations like this, yeah, ask before telling. So ask the patient if they want to know the details of the medical condition or treatment. Example, yeah, I'd like to go over the results. Would that be okay? Look at the reaction, yeah. Accept the patient's right to know, right? Offer to answer any questions the family, the patient, the family member may have. Okay, so this is invitation. And please, yeah, do not delegate to a colleague or subordinate. You are the boss and you say to the registrar, kau buatlah. Aku ada banyak kerja lah. Kau cakap lah dengan patient tu dia ada cancer stage 4. So that's not good, yeah. Or do not go to your colleague. This may happen sometimes because you're busy and those people are doing both private and public practice. It's difficult. They will pay more attention to one sector and then forget about the public patient, which is not good, yeah. You never delegate breaking bad news. I've mentioned avoid medical jargon, yeah. Speak as you would speak to your mother-in-law, I'll say this, no? Provided your mother-in-law is not some famous consultant. So mention a thyroid enlargement example instead of non-toxic multinodular goiter. Why you have to say that? Okay. And fill in any gaps that were evident in the perception stage. So you just take notes, what the patient understood, and then just fill in the gaps in their perception. Present the information in small chunks, yeah? So that after each chunk, verify the patient's understanding. Example, are you with me so far? Yeah. So say things like that, so that you read in chunks, not just a continuous speech you give. The patient will not follow you. So this is the E, the emotions, yeah. How to cope with that, how to handle this. So deal with emotions as they occur, yeah. Not like anticipate before they occur. Remember, your patients are very emotional, will not comprehend what you say. They just got a thought block, they cannot think anymore. So you've got to do it in slowly, just as they come. And in this part of the communication skill, you have to use both open-ended and direct questions. So like, can you tell me more about how you feel? Did that make you angry? Yeah. And use affirming statements. So exhibit empathy. I can see you weren't expecting this. I've mentioned that you have to have a box of tissues available and about touching the patient. Lastly, for spikes, sorry, this is second last slide for emotions. Use phrases like, tell me more. Yeah. I don't know how I'm going to tell my kids about this, the patient might say, and then you say like, tell me more about that. You don't straight away suggest what they have to do, and try to keep your own emotions from taking over your demeanor. This is what called the 6-second rule, can be 5 seconds. Yeah. If your emotions start to boil, right, you just pause first and avoid being defensive or blaming. Yeah. So do the 6-second rule. It might take longer for some of us, yeah. But do not let your emotions take over the interview. Avoid responding with false reassurance, such as, everything will be fine, don't worry. I've seen lots of miracles happen. These things are not to be said in breaking bad news, yeah? So don't be unrealistic about these things. So dealing with emotional patients, let's set an example. Don't ask patients to calm down. You model calmness. You show that you are calm, so they will model you. Yeah, you're the role model. Listen to the needs, concerns, and unexpressed expectations of the patient and the caregivers. And use words like, to help patients settle down. Do not argue with the patients. Use what we call disarming statements, as I said earlier, yeah? I know where you're going with this, or, I can understand your... And say no in a tactful manner or diplomatic manner if the patient's requests are unrealistic and not possible, yeah? So you have to be tactful, but this requires some practice. And acknowledge emotions by empathizing, like, I can see you weren't expecting this. This isn't easy to talk about, is it? It's very stressful, isn't it? It must be hard to come here every week. Doesn't matter what they say, you just have to be cool. They might say, how do you know all this? How do you know I'm stressed? I can see how difficult it is for you. And lastly, I wish we had a more effective treatment. Things like that. So this shows empathy, right? Rather than being careless about it, not C-A-L-L-O-U-S, careless about this. Couldn't care less about it. Avoid phrases like, I know how you feel. I feel your pain. That's not good, yeah? It's going to be all right. Take it easy. So that's also not the way to break bad news. This is very similar to the one I mentioned earlier for patient consultation. So deciding on the best medical plan for the patient, best medical plan, clarify expectations of a treatment outcome, recommend a strategy, collaborate and agree on the plan, and good to ask the patient to repeat what they understand with the plan. And I've mentioned earlier, using a whiteboard, a piece of paper, writing down the treatment plan clearly for the patient to take home. Yeah, make sure your handwriting is clear. Yeah, you can type it on the computer if you are good at typing, and then can print it out for them. Type it in front of them. Summarize the conversation, and be prepared for tough questions like, does this mean I'm going to die? Yeah. And then you can tell them, tell me more about what concerns you. Can I be cured? I'm sorry to say that it is unlikely, yeah. And our responsibility is to keep it in check, yeah. How long do I have to live, yeah? So these are things that they will ask you, and you must be ready with those bullets to shoot back at them, yeah. I call them bullets, because if you don't have these things ready, it's difficult to come up with a sentence which is empathizing. Okay, lastly, yeah, if I may, Prof. Laila, I'm going to talk about history taking, but very briefly, because it's not talk about that, but it's still communication. I want to show you Raymond's philosophy, which a lot of you have seen probably. This is my philosophy, right? When you are seeing the patient, you are a detective. When you are presenting or discussing the patient with your examiner, with a colleague, with another lawyer, then you are a lawyer. And only when you're formulating a treatment plan, you are a doctor. So you have 3 roles in one. Why detective? History taking actually is an interrogation, not quite CIA or KGB, but it is an investigation of the where, what, why, and how of the patient's problem. So in a murder case, it would be like to answer the question, who's done it? And a detective never leaves any stone unturned. He or she will explore all possible explanations of the patient's complaints. Yeah. If you miss one stone, this is a peribahasa, yeah, a proverb. When they go fishing, they look for worms, and they will on the soil, they will turn over stones and looking for worms where they hide usually under stones. So if you leave any stone unturned, and that is the diagnosis, you end up in court facing another lawyer, whereas you are trying to be a lawyer yourself. So that's not good. Why a lawyer? Because you, when you present your case to anybody, yeah, you're going to present all the evidence, just like a lawyer, derived from the history and examination to defend your diagnosis. And candidates who can do this well in the exams, yeah, in the long case or any exam, yep, I will give high marks, yeah, because they speak like a lawyer. I'll give you some examples. So the process of history taking is not very difficult, different from the consultation. You have to greet the patient, greet by name, appear interested and sympathetic. Yep. Introduce yourself, who you are. You may think they know you, that you're so popular. State the purpose of the interview, right? So saya nak interview Pak Cik ni, saya nak interview Cik Ali ni oleh kerana saya perlu mendapat maklumat, blah, 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 okay, and so on. So you have to state the purpose of that. And you start with open-ended questions. As always, how can I help you? What seems to be the problem? And I like this good last one, which is, when were you last well? This is probably the best one, yeah? Because I've noticed over the years when I examine long cases, students often miss the last admission, you know? So they might cover one, but they did not find out about the last admission. And during the history taking process, again, very similar to consultation, you show interest and empathy. I see, I understand what you mean, where you're going to. That's clear, please keep talking, things like that. But listen first. And please do not repeat the same question if a satisfactory answer has been provided. Patients do not like that. You know, patients may think that you think they are dumb, or you think that they think that you think that they are deaf, you know, like you didn't hear the question. So it's more like you are deaf, you know, if you're repeating the same question. And avoid leading or biased questions. This is very common in the exams, you know. I've seen this happen because nowadays we, you know, even the MRCP exams, we look at how people take history, and candidates will tend to lead them to a diagnosis. And patients, being patient, they will agree. Oh yeah, hari tu saya sakit lutut. No, actually they didn't have that. And you start making the wrong inference for this. Yeah? Again, maintain eye contact. This is important. Do not look at your watch as if you are in a hurry. And I mentioned this again. Yeah? Make the patient feel that he or she has your undivided attention for an indefinite time. But actually you don't. But that's a way to communicate your body language. Just looking at the watch is good enough to say, or yawning in front of them, you know, that's not good. I know sometimes you have to yawn because you were on call, but try to avoid that, yeah? Because that shows that you're not interested. That gives the impression, that you're not interested. Avoid writing as you listen, yeah? Don't look like a reporter. It's better to take short notes and then look at them. More important to have eye contact than to have paper contact, you know? So this is important. This is another important step, the communication during the physical examination. We check this, how you instruct the patient. You must speak loudly in the exam, for instance, or in real life, right? Clear and concise instructions. And instead of saying, do you have pain anywhere, use this phrase, let me know if I hurt you. A lot of people assume that pain and tenderness are the same thing, but they're different. Do you have pain anywhere? Yes, my right wrist is painful. So you examine the hand, you start with the left wrist, and the patient screams and you fail the exam. Pakcik kata tak sakit. Patient pun pandai, itu tak sakit. Doktor picit sakit. That's called tenderness. So it's better to assume everywhere is tender and give an instruction that rather than taking a history, let me know if I hurt you. And looking at the patient's eyes and face, see whether they're whinging in pain as you slightly touch them. Yeah. It is best to continue history taking of standard questions like, you know, if you have any allergies, do you smoke, and so on. how many brothers and sisters you have, while examining the peripheries and abdomen. Cardiovascular, the heart and lung examination, of course, the patient has to take breaths and so on, stop breathing and so on. You cannot ask questions, but looking for clubbing, looking for lymph nodes, examining the abdomen is a good one to ask questions, because that will make the patient more relaxed. You notice that you ask the patient to relax, they're still not relaxed with the abdomen. But if you distract them with questions, not too difficult questions, easy questions, like, as I mentioned earlier, tell me about your allergies, but you must try from now until the day of your exams, remember information that you obtained during the examination, because you cannot write down while you're examining. So you have to retain this, in your memory banks. And demonstrate compassion and a caring attitude all the time, what I call smile confidently. Don't smile stupidly, like a grin. You have to smile, but show that you're confident with your technique and so on. So this is very important, rather than look strict. I remember when I was a kid, jumpa doctor takut, because doctors never smile at me. So, but give a smile and examine in a confident way. Some examples, what doctors often do when taking histories like this. I'm going to end in the last 2 slides, or 3 slides. A patient gives you a problem. Example, I always like chest pain, and sudden severe central chest pain. What we often do is to think only of symptoms pertaining to either the CVS or a myocardial infarct. So you ask about, do you have breathlessness? Do you have palpitations, sweating? These are correct, but you are limited. You have a narrow angle lens. You are narrow-minded, so that's not good. So because of this, you cannot expand on the history anymore. Physical examination will not be focused and unguided. You will miss important investigations, and you don't know how to manage the patient comprehensively. What you should do, if someone comes with chest pain, because they don't come with a diagnosis, you think of differentials first. Whether you're a surgeon, physician, pediatrician, obstetrician, I know you all are from various fields, pathologists, radiologists, you have to think of differentials first, because by doing that, you can expand on the history. If I did not think about pulmonary embolism, I wouldn't have asked the patient, did you travel long distance from London to KL, for instance, for 13 hours, sitting in your chair? Then you think of DVT with a pulmonary embolus to the lung. If you didn't think of aortic dissection, you wouldn't have thought about asking for radiation to the back, or you wouldn't ask the patient, if you sat up and lean forward, does the pain get better? That's pericarditis. You wouldn't think about that. And you wouldn't know how to examine. If you didn't think about pericarditis, you wouldn't examine all the pulses in the lower limbs. If you didn't think of pericarditis, you wouldn't examine or listen carefully for a pericardial rub. And this is often missed, pericardial rubs. You wouldn't know how to investigate everything, You miss, again, you do not leave any stone unturned. So you have to investigate, especially if myocardial infarct is not there, what else it is. It is. And of course, you will know how to manage the patient safely and comprehensively. I'm going to end with this cartoon, if you have an average doctor and you take a history, you examine the patient, you communicate with them, right? They give you raw material, all, like this, and then what you do is you just regurgitate raw material, you write in the notes a diagnosis, what I call a label. But you're a super doctor, right? They give you raw material, you analyze, you think, you communicate effectively. What you will get is KFC, a consumable product. And that's what I want all of you masters, students of UKM to be like this, a super doc. Okay, thank you very much for your attention. And I don't know if there's time for questions, Prof. Laila. I will stop sharing, I suppose.
Yeah, thank you very much, Professor Dr. Raymond. That's very interesting and enlightening talk as usual. Right, so we'll see whether we